Well, good afternoon. Welcome to the THCB Gang. I am your host, Matthew Holt, the founder and publisher of the healthcare blog at Boltyboy on Twitter. Really looking forward to this afternoon's conversation where I've got a couple of guests come in and then three of our regulars. So it's going to be a lot of fun. And who is on the gang today? Well, three regulars: Kim Bellard, all the way from the world of marketing and regular on publisher on THCB. Michael Millinson, way back when, author of Demanding Medical Excellence, Healthcare Quality Guru, and Ian Morrison, futurist of renowned, missing the golf course in Scotland where he should be today. Poor chap. And then two guests, good friends of mine from a long time back, Maggie Carey, who is a way back, was in the Clinton administration, running their telemedicine policy. Remember that? Wrote a book about it 20 years ago. We'll ask her if anything has changed in telemedicine in 20 years. But these days, much better known for doing executive coaching primarily for physicians and clinicians. And Steve Woodell, longtime analyst and investment banker, now running his own organization, Stephen Woodell and Associates. I hope I got that right, Stephen. And we are now ready to go live. Well, welcome everyone. Great to see you all. And it's now what? Week 78,000, day 4,028,000 of lockdown quarantine. You can tell who's doing their own haircutting or not. I was on a thing this morning where Shafi Ahmed, the MD from London, he had very close cropped hair, and I tweeted him and said, "How do you do it?" He said, "I did it myself because I'm a surgeon." He said, "We used to be barbershop surgeons after all." Anyway, so here we are. So I will start off because I normally let everybody else go first. But the big thing of the week for me has been that those damned, I sound like a Republican, those damn trial lawyers have ruined my life again. Being a faithful consumer of Johnson's baby powder, it's been taken off the market by J&J because they were being kept on being sued by people who claim that it caused various types of cancer. And who knows if it did or it didn't, but my butt is going to be a bit sweaty from now on. That's too TMI. Anyway, well, let's go around the horn and find out what else have people noticed that struck their fancy in the last week or so. Why don't I start with you, Kim?
Well, you got to start with the 100,000 dead, 40 million unemployed, but fortunately we can go to the beach again. So there's our priorities.
Indeed. Well, you summed up the conversation pretty quickly there. Michael.
I think what we're doing is we're trying to change from a medical emergency to a healthcare emergency, where we're starting to worry about the healthcare system again and about the economic aspects that affect on hospitals, about access, about all those healthcare issues, as opposed to only the medical emergency of our people going to get treated and die.
Right. Steve, I'll introduce you a little bit more in a second, but just for what you've just seen in the last week that struck your fancy.
Right. So a couple of things. One is the continued riddle of the stock market at high levels, and yet real economic dislocation, real unemployment, real demand destruction, real GDP contraction. And so I call that that we're suspended in a Wile E. Coyote moment where the coyote has run off the cliff and doesn't realize that gravity applies. But when he realizes, inevitably, then gravity will apply. So that's the first element. The second is I think that the big story right now is opening up. And I think that if you are smart and you open up smart and you have a competent state and trust of people and excellence of technique and science, you can open up safely and you can have you can have a relative return to normalcy. But if you open up and you can't do that, then you have kind of the worst of both worlds. And we're watching that. You have infection spike and you have ineffective opening up at the same time. And so we're watching that play out. So I think those are two of the really big stories. And then the last is from a digital health perspective, and I focus on the intersection of digital health and the capital markets, is what I call the emergence of green shoots. And the emergence of green shoots is that investors really weren't investing in digital health. And now we've seen a couple of deals happen. And that could signal more, but it's too soon to say.
So. Well, we'll definitely come back to that in a minute because that's something I watch very closely as well. Although I may take the next week off and go to the Lake of the Ozarks to have a bit more fun. Maggie, what have you what's come to your attention in the last week or so?
So there's an article in the Annals of Internal Medicine that says the coronavirus test has 100% false negative on the day one. And having had one of those tests, which hurts a lot. That was interesting. Second thing is my clients' biggest concern right now is opening up and for the safety, and actually there's a lot of physicians being laid off, mostly not really my clients, but people that work with them. Those are the things I'm thinking about.
Ian, I see you drinking your mint julep.
Yeah, exactly.
What have you noticed the last week that struck your attention?
Well, I mean, I think all of these are great topics. I'd love to come back to many of them, but the one that's gotten me a wee bit obsessed is state budgets, and the potential 20 million increase in Medicaid rolls and Mitch McConnell not bailing people out became personal for me. I mean, as you know, I'm on the Martin Luther King board in LA. We got through COVID, even though half our hospital was full of it at the height. But what's going to kill us is the fact that Gavin Newsom's budget is going to zero out the special deal we have in terms of payment rates, which would reduce our revenue by 10%. And so the knock-on effects on states of all of this, I don't think has really gotten enough attention. And if McConnell doesn't allow some kind of relief, I think there'll be ugly stuff and pressure at the state level.
Yeah, it's worth remembering that the last time we had a really big federal bailout, which was back in 2009, about half the money, a bit of it went to EMRs, a bunch of it went to other stuff, some went to Tesla, God knows what, but about half the money just went straight to states to replace the collapse in their budgets in that time. And we haven't really seen so much of that. And the rapidity of the unemployment increase, and who knows how, what's going to happen to it, and it is really been, I think, something that we haven't fathomed. You are seeing a lot of reports of people who don't have insurance and also haven't even been able to get unemployment benefits. And you're seeing those massive long lines of cars all over the country waiting for food banks, so for food bank supplies. So I think you're dead right. This is going to really come to get us in a couple of areas. The one other story I noted the week, which was I saw on Twitter, which is kind of an interesting inside healthcare story, but there's a bunch of Blue Cross Blue Shield plans are suing CVS, and not the part of CVS that has Aetna does the health plan, but not the part that does the retail stores, but the bit which is the PBM, for inflating generic drug price costs on them, and apparently selling them for cash way cheaper than they would sell them to the plans. And maybe there's a bit of the sort of the dog we call it catching its own tail, and that kind of price go round that's been going on in healthcare for many years. And I know we all been looking at that for some years. All right, let's dive in. So let's start. There's a place where I can start. I can get both Stephen and Maggie on the topic. So Maggie, 20 years ago, you wrote a book about telemedicine. Why not? You've got it.
There you go.
Look at that. And that was, I was joking with you beforehand. Mostly it was about, there's that one city in Norway where they figured out telemedicine. It was Mars in the Arctic Circle. They couldn't get any doctors to go there. So they used telemedicine successfully. And there was one prison in Texas or somewhere that also used it. And it was this great idea and no one else used it for 20 years. What was it like then? What's it like now?
So it's interesting because when I wrote the book, it was really hard to get it published because all the publishers said it'll never happen. Nobody's ever going to do telemedicine. And that was when I was in the Clinton administration and I had the lead on this. And so what's interesting, I think, is a lot of the same issues that we had. I was on I was on a lot of national and international committees on telemedicine, and the things that we had said were barriers then, a lot of them have been barriers now for 20 years, among them reimbursement. And that's slowly changing. The other one is the regulations, which is the doctor going to the patient? Is the patient going to the doctor? When I sat on the state medical board in Colorado, there was one doctor who had a license in every state so he could do radiology. That's very expensive. And I think that, and I remember going to the National Academy or whatever it is of state medical boards and having each board say, well, we don't know about the doctors if they're very good. So that is sort of changing right now. The reimbursement is probably going to be less than it is for a full-time visit, but patients are going to say, hey, I mean, I have Kaiser and I do it with Kaiser. It's so much easier just to go online and the schlep all the way downtown DC, wait, come back. And so I think that the patients may drive it. I don't know that that's the case. What we wrote about in the book is still really applies, a lot of it. What's changed is the technology, and the technology will always change. And I think that, but we're still struggling in some ways with reimbursement. We're still struggling, again, will be interesting to see what happens when coronavirus goes away and reimbursement. The other issue that was talked about was, what if the equipment fails? Whose fault is that? And I did go to Galveston. I went to the prison, did a site visit to see what they were doing with telemedicine. It made sense for prisons because it was so expensive to transport prisoners, and also problems with safety.
Yeah, I mean, it's certainly a different world. The technology is different now. We all have the ability to get on the other end of one of those video calls in our pocket. I did see a very interesting article by Rishika Fandanopoulos at IORA, looking at their change. And they already were using, because they're basically a capitated medical group, IORA. They already, for their Medicare Advantage patients, they're already using, you know, a significant amount of virtual calls, but they were basically phone calls. And they bumped up the number of phone calls they did. And eventually over time, they transitioned that over the recent weeks, they transitioned those to video. And in some cases, for some of the elderly patients, they had to go around and physically take an iPad or whatever it is, a laptop or whatever the hell the thing was, and actually show them how to set up and how to use it. So there's some real work involved in getting some of their patients on the other end of that. But we heard Grace Cordovano was on the gang last week talking about how her mother, who was getting on in years, is now doing telemedicine with her primary care docs, and things are definitely changing for those intense use patients. So Stephen, you've been looking at that, not only because you follow Teledocs, and they've been kind of the breakout success story, or one of them, along with Livongo in the stock market. But there's a bunch of other telemedicine deals. American Well just raised nearly a couple of $100 million to sort of go in the pot this last week. Give me a sense about how, from your day job in the capital markets and looking at digital health, how do you think this is playing out, and how do you think that this transition to telemedicine is being seen by investors?
So a couple of things. So the first, and by the way, I was the first analyst to cover Teladoc when it went public, and I remember
you're probably the only one for about 5 years, weren't you? I'm kidding.
They
not
had
quite.
a line that they said, which was that in primary care we can adequately care for about a third of the most common reasons people use primary care. That was their sort of line. And then over time, we saw them keep expanding and go into behavioral health and go into other areas. And really the resistance, people so initially investors didn't buy that Teladoc would be a good substitute for a third of the most common uses. And they also didn't think people would use it. But Teladoc had to fight that for a couple of years in the markets, and then it became identified as more of a winner. And now it's had this amazing thing happen to it. But I've heard some clever stories, like I've heard of a doctor having someone's wife hold their iPhone with the flashlight on and point it in their ear when they had an earache to see if there's redness and swelling in their ear. So the physician on the other end can see it without their having to come into the office. So investors are very hot for telehealth right now. I think the way to look at it is it's two things. It's a combination of telehealth and remote monitoring. And we'll see companies that offer these together. They sell into the employer market, also into the provider market. So American Well is more focused on the provider, and Teladoc is more focused on the employer. There's continued very strong interest in those. And then we'll also see, I think, providers increasingly having to have a digital front door, and that digital front door is a website or an app, and they have to figure out infection control, and infection control is going to mean having a new front door and being digital first. So the last is that in general, the consensus among investors is that even in digital health, COVID is bad for 95% of companies and good for 5% of companies. This would be the young, innovative companies. And telehealth and remote monitoring are right up there with the 5% that it's good for. Yeah,
I mean, I'm pretty staggered about how many deals I've seen that have actually been going on during the time of COVID. So I was on a call yesterday with Alex Morgan from Kozler Ventures. Now Kozler is known for scattershotting money around the digital health and any other space that thinks is interesting, with the exception of surfing companies. Everybody gets some cash out of them. But he said he'd done 3 deals now, where he just purely done the deals over Zoom, hadn't actually physically met with the teams he was investing in, which seems to me, and you're seeing some of these really big numbers being put in. So Mindstrong, which is a California-based company that has a deal with mental health, has a deal with the state of California in various counties. American World, both raised 100 million plus. So we're not seeing those areas close off. Now I agree that you mentioned behavioral health, you mentioned telehealth, dermatology, some other things that are easy to translate, and also those companies that are making the thing that you can show in the ear, like Taito, Wellness, and the others, and it's sort of blending between the remote monitoring and the telehealth piece. It's all kind of coming together the same way that Maggie said the technology is changing. But I guess my question to you is, if you look at some of the valuations of these companies, go back to what you said about, the Wile E. Coyote moment. You're seeing some of these companies now are being valued at sort of 15 to 20 times future revenues, which is revenues, forget profit, revenues. And Zoom, I think at one point was valued at 40 times future revenues. When you looked at the stock market for a long time, the way you have, and a lot of us on the call have, what's your sense about, yes, it's a big thing, people are getting attention to it. These are relatively small market cap companies, even if they're 5 to 10 billion, they're not, Google or Amazon or Tesla quite yet. But I mean, how long does this go on? What happens next in the kind of stock market evolution of this sector?
It's a really good point. So those valuation levels, would sound a little bubbly, and I've seen numbers like that as well. And yet here we are. If there was ever a popping of a bubble, it would have to be a global pandemic emergency, would be the popping of a bubble. So what's going on? Why is it still happening? So at one level, there is that if the growth is high enough, it can actually justify it and not indicate a bubble level pricing. So, for example, any growth over, say, 50% is hyper growth. Maybe these companies are growing top line at over 100%. Maybe they're growing at 200%, and that can start to justify those numbers. If you don't see that level of growth, then you have to wonder about those kinds of numbers. A second way of looking at it is that this is just in the sort of the hot sectors, so telehealth, remote monitoring. There's other areas. I would say clinical trial automation is another area that's going to be really, really hot for a while. Remote distributed devices, distributed care models, and there's a lot of areas we could talk about. But I think you will see. I actually did a webinar with Lisa Sunin recently, and she talked about how what she's seeing is, some deals aren't getting done. That's very clear. Other deals are getting done at former prices, but they have terms like participating preferred at 2x that weren't in there before, and that's a way of bringing the price down. Pricing is sticky. Deals don't get done if one party unrealistically demands a high price when a high price is no longer justified. A way to get it done is to put in terms that capture the value back out for the investors. And so she's seeing a lot of that happening. And then outside of the hot areas, deals aren't getting done. But then another factor in here, I would say, is that I'll call it the bubble of everything, which is that we've been living in, and we're still living in, this worldwide bubble of everything, where there's more money than there are valuable properties, and that tends to mean that when something looks good, it can command an outsized price, because there's just not other alternatives for it. There aren't other growing assets out there, and so in the whole world, there's like three growing areas. There's international, there's tech, and there's health tech. And so we're in one of those areas where it's hot as a category. Lastly, I'd say that you're also seeing that among young companies, the ones that have really stood out somehow by having hit products or being backed by top investors, they're capturing these rewards, and the ones that weren't are suffering right now. And then also among funds, the funds that are the famous funds, the big name funds, they feel free to invest right now. And then the young funds, the small funds, the special purpose funds, the first time funds, they're struggling right now. And so you're seeing it, but we get to see the really exciting ones getting done, but there's a lot at the edges where people are not feeling good, and they're not seeing high prices, and they're not seeing this working for them.
Okay, and before I let you go off the stock market thing, the one last question I have for you is One Medical, right? Went public in January. Kind of went, it's a bricks and mortar establishment that charges pretty high prices, and there's S1 for what it does. I happen to be a member. I'm a very happy member, but went down and then seemed to go skyrocketing up. It's cooled off a bit since. But I mean, give me a sense of, why did it go up so much? Was it regarded as being a telemedicine company instead of a bricks and mortar company? That fooled me.
So, I don't have a good answer to that, and of course we've seen a lot of gyrations where things don't make sense. It's a really good question. I'm a happy member of it too. I can also say that they effortlessly all shifted everything to televisits, with the crisis, and so right. So I don't know. I don't know if I agree with a very high price for it right now, because among other things, Americans are going to feel poorer. Companies are going to break their social contract with their workers and offer fewer benefits, and so that's an area where for people to pay extra for a premium primary care service. That's on the chopping block for middle class families to cut, I think. But it does offer an interesting model for the future. It doesn't have an amazing infection control model other than switching to telehealth like other people are doing. And so I don't know why it's gaining a lot of benefit recently.
Oh, we'll see about
Matthew,
that. Yeah,
Matthew, I'm curious whether you and Steve, do you think the telemedicine companies are going to focus solely on growth and managing what they got now? Or are they going to be looking for deals with remote monitoring and wearables and so on to take around?
I cannot see any possibility that if you're sitting on you're sitting on Teladoc stock price, you're sitting on the Livongo stock price, you are looking at a whole raft of areas you can get into. And I think we talked about this last week. For the chronic care management folks like Livongo to get into more remote more remote acute care and active care, and then maybe sort of blend into telemedicine and vice versa. I don't see how these two don't end up together. And we talked a bit about this in previous weeks. What are the big quote unquote disease management companies, i.e. Optum and other stuff, thinking about doing? Optum just bought a post-acute care player, NaviHealth. So you ask Steve will give you an answer, but my sense is that they've got to start thinking about what else they're buying, because when you're sitting at that time of you've got to start spending your money, spending your capital, I think.
So analysts who look at this are seeing hubs emerge, and the hubs are, so just to name some of the hubs, and I'll name the hubs that serve the employer, but they're analogous to other areas. There's a navigation, guidance, and wellness hub. There's a telehealth hub, and that's Teladoc and American Well and others. There's a chronic care hub, that's Livongo. There is a benefit enrollment hub, that's Benefit Focus and others. There's other hubs. And so for Teladoc, I think they've said their explicit goal is to be the telehealth and remote monitoring solution for employers, and then the other big budgets as well. The next one would be providers after employers, for example. So and what happens is they become a hub. They have a single platform. They have a suite of products, and then this becomes and then they also hire a big expensive sales force to sell direct into the budgets. And then this becomes an unbeatable combination. And then on top of that, they get a high stock price, a high currency, and this allows them to add the parts of the suite that they don't already have at a comparatively cheap price because they have an inflated currency. So I think you'll see a rapid emergence of multiple of these suite and platform companies, and the obvious ones to look at are Teladoc, American Well, MD Live, Doctor on Demand.
Right. So Maggie, I want to bring it back to you now. I want to sort of get to your old world and your new world, as it were. So one of the things that Steve mentioned is there are a couple of now tools, and I saw a bunch of them yesterday in this mental health breakout I was at that Veda TV put on, which are like doing essentially remote monitoring, sensor-based tools, which are now feeding back into a wider system. Some of them are now looking at stress and God knows what else. Steve mentioned the ones which at the moment it's used pointing the iPhone into your ear, but there is the tools like the Tydo Care product, which actually you can imagine adding onto telemedicine very easily. So that's a change, right? We're talking about now, can we do all of our stuff? Can we do more and more things that would require a physical exam, to be done using these types of, can they be done using these types of tools? Now we're talking doctors have to change their behavior. You spend a lot of time talking to doctors, not only about telemedicine, but how they change their behavior. That's your day job now. How do you think the clinicians, the medical professionals is going to take this?
So I think right now doctors are feeling commoditized. And if you think of healthcare as a cartel, there are three members: the large provider organizations, the payers, and pharma. And you'll notice that doctors are not in there. And so and doctors have more than 50% burnout now. So I think that I think it remains to be determined how they're going to work it out. I have to say, I don't coach any burned out doctors. That's not my market. But I think that part of it is learning to work in teams and realizing that patient care is a team sport. So how are doctors going to change? The other thing is, are they going to be liable? Say that it's a constant sending of information, whether it's like a Holter monitor, a 24/7 Holter monitor, which is a thing that you put on to measure your heartbeats and arrhythmias in the old days. What if it's that and the doc misses something? Or what if the doc misses something from a continual pulse oximeter, which measures the oxygen in your blood? And I think that stuff remains to be determined. I think that doctors are feeling under siege about a lot of things. Michael.
Maggie, when you say burnout, what do you mean? Do you mean discouraged, or do you mean literally not practicing medicine, don't want to return to medicine?
So burned out has a definition, and it's when you feel hopeless, when you don't feel that when you're not feeling rewarded. And I can speak to that about my clients, that they really do feel commoditized. And if you look at the number of administrators that have grown compared to the number of clinicians, doctors and otherwise, over the last 20 years, it's a very interesting curve. So I think burned out actually has a definition, and it's not just I'm burned out, I'm going to go away, but it's that I don't feel life's useful anymore. I don't feel I'm contributing. I don't feel valued. They do a thing called pajama rounds in the evenings. That's they go home, have dinner with their families, and then they put the information into the medical record. And I think Michael wants to say something.
Yeah, I was kind of on what you talked about some of the other liability issues, but first, what Steve asked, I think, is important because as much as physicians are under stress, the problem with the term burnout is it has a plain English meaning, which is not the meaning that's being used in regard to doctors, right? Mm-hmm. And so, so the plain English meaning is burned out. If a forest is burned out, it doesn't, become a forest the next day, right? Whereas the definition in regard to doctors, which allows them to throw this 50% number in, which is like, if you look
53% actually.
Right, and what the 53% is, which makes no sense, right? If you think of it in common sense, are radiologists in Mississippi burned out? I mean, 53% of all doctors, no way. But when you look at what it means technically, it asks at least once during a week, have you felt these, and there's this definition of the stress. And so if at least once a week you feel these awful feelings, it goes into the definition of burnout. And as we address this legitimate issue, in order to keep from being overwhelmed by physicians' self-pity, we have to start to understand the difference between people we're losing and really harming, and the fact that an orthopedist in North Carolina who's being paid fee for service occasionally once a week feels bad, right?
Oh, I'm gonna push back on you. Burnout is a long-term stress reaction, long-term, marked by emotional exhaustion, depersonalization, and a lack of sense of personal accomplishment. And with all due respect, I think using self-pity is a little bit negative. And so I would.
Oh, so Maggie, I looked at the questionnaire because I'd heard the term. So again, you have to ask yourself whether or not the term burnout means they're out, they're gone, they're fizzed. Have we lost 53% of our doctors? No, absolutely not. That is not what that means in plain English. If you ask whether we're stressing doctors unnecessarily and that's dangerous, absolutely yes. But when you look at the questionnaire, some of it says, have you felt this, one time, and people ask it. So we'll do that offline. It's a real problem, but having read medical journals for 30 years, do physicians engage in self-pity? Absolutely, they engage in self-pity. And because physicians are smart and articulate and they're really good writers, they do self-pity really well, much better than plumbers or even Republicans. I'm
not sure about that one.
but
I'm not touching this one.
Yeah.
The other question you asked, but I thought you raised a terrific point about when you go to all the telehealth and everything, the liability for the dashboards and this, that, and the other thing. Because if you take a doctor who's seeing patients, you really want to don't burn them out, right? And you give them all this extra data stream and you don't give them any help and you don't give them any way to interpret it. And they're coming from 5 different devices from 5 different manufacturers and God knows their accuracy. You know, it's just a prescription for chaos. And I think that as we move to the information age, we have to do it smartly and value the brains of the doctor, the judgment of the doctor, and all the rest of that, or we're really going to burn people out, all to increase the price earnings ratio of the companies making the technology.
Yeah, I mean, let me just jump in here because I think you're all making good points. That I mean, when people talk about burnout compared to what, right? I mean, everybody's burned out. I mean,
right, exactly.
So it's not like an uncommon thing. But I think Maggie nailed it. I think burnout is the wrong term. The term I tend to use with people is demoralization.
Yeah, I agree.
And a lot of it has to do with
and that I agree with completely. But Ian, so the balance is, because everybody's under stress, we want a certain amount of demoralization to transform healthcare, right? So I want the orthopedic surgeon or the ophthalmologist who was doing, 20 procedures at once in the round and billing Medicare with using assistance. I want him to be demoralized at losing $2 million of income and going down to 1 million, but I don't want my pediatricians and my primary care physicians and the kind of people that Maggie is working with to be demoralized, right?
Right, but there's a danger that we could have a cyberchondria version of demoralization, right?
Exactly.
That it's, I mean, I think that's what you're driving at, that absent certain, I mean, I've worked with Kaiser for 30 years, and they have their own equivalent of burnout at Kaiser. I mean, they joke at Kaiser as Saturday night used to be date night, and now it's for Epic, where you spend catching up a week worth of notes.
Ian, what's the problem? Ian, they're still getting screwed. What's the problem?
Oh, family show here, Dr. Mr.
Yeah, but yeah, no, but funnily enough, I did a gig for Nuance a couple of years ago, and I was this panel with this radiologist from Alabama who said, "Oh, we've been using scribes for 12 years, and it's all working with voice technologies. Brilliant, brilliant, brilliant." He said, "But even the scribes are burned out."
Yeah,
I thought it was pretty funny. But while we've got these great experts here, I mean, to me, there's been this conversation, Matthew, over the last 6 or 7 I've been involved in of these wonderful gangs, and it really is on the telehealth thing. Is this a moment where it's just pure substitution of a visit for an electronic visit, or is it a tool for transformation of care processes? Right. I think that's a much bigger question. And then the related big question is, who's the customer here? And as in customer, not who could benefit, but who's paying for it? Is it the plan? Is it the employer? Is it the health system? Is it the consumer? And I would rule out the consumer paying for anything, and you're left with those others. So I'd love to hear from Maggie and Steve and Kim what they think the answer to those 2 big questions are.
Okay,
I want to give two examples of stubbornness in the healthcare system that I read today. First, I think it was Paul Levy tweeted it that some healthcare organization is now letting their doctors do telehealth, but they have to go into the office to do it. I don't really get it. And the second one was an article that Michael wrote today or yesterday in Forbes about after all these years about trying to get doctors to wash hands, we're in a pandemic and they're still not washing their hands.
Nor are surgeons using checklists.
Well, Ian, so
the healthcare system is remarkably stubborn.
That's too high tech.
So Ian, I'd say an interesting 2-pronged answer to your question is that so when the crisis is deemed to be over, will we see a return to telehealth to its old position, or will we see, so right now we have expanded rules of access to telehealth. We have expanded rules of qualification for providers to cross state boundaries. We have reimbursement, in some cases parity reimbursement, which is the biggest issue of all in telehealth. And these are all on a waiver or emergency basis. And so the question is, when it's over, will these go back to the way they were? And I've heard a lot of arguments saying that state borders will go back to the way they were because doctors in states have a lot of political lobbying power and will try to put that back into place. And so then it becomes an issue of, health plans have a tradition, payers and government have a tradition of thinking that things like telehealth increase utilization without improving overall care. And so are they replacements or are they an addition somehow? And clearly right now they're replacements, they're not additions. And so, but if payers come to see them as being additive, then they will try to restrict telehealth. And there's a tradition of them having seen it that way in the past, so they may return to that. That's one force that we should watch carefully. And if I had to bet, I'd say that I actually would bet against that. I think we're going to see a parity of telehealth in qualified cases going forward. But I think that's a controversy right now, and we should watch it carefully. And the second issue is young people who are not payers, but young people think that healthcare should come to them from their phone, and it's broken if it doesn't. And so there's going to be a preference in young people, and the pig's going to move through the python. And so I think that can still be a powerful force for change in the direction of telehealth replacing healthcare instead of being additive. But they're not paying, and so they don't necessarily have a say.
Well, there's a couple of, let me butt in, there are two things. I want to go back to Maggie on this, but there are two things. One is, there are a group of very specific telehealth companies who are not the ones you mentioned earlier, but the people like Lemonade and Hims and Roman and, who will sell you your floppy dick pill or your baldness pill or whatever happens to be, a UTI patch, who are nerds, who are very specifically going after that cash below the deductible number, who've been growing very fast, and that's a direct to consumer play. So the consumer will pay for some stuff.
Right.
Now, and related to that, and I want to get back to the burnout plus telehealth thing, because maybe people are burned out by doing too much telehealth and too many Zoom meetings. But you're seeing a massive spread and massive growth, not just in telehealth, but also in behavioral health online, behavioral telehealth, right? Part of that is back to the point that where Michael and Maggie were helpfully arguing about what's burnout, right? Which is virtually everybody at some point has got some signs of depression or anxiety or something. Not that many people who've got very severe mental illness. And you're now starting to say, which ones of those are we treating using this behavioral health expansion that's going on now? Companies like Lyra and Quartet and Silver Cloud Health, all these guys doing this. But also, I was just on a thing this morning with Livongo owns the behavioral health sub, is doing the stuff with Kaiser, who's now getting you to, it's called My Strength. And then they also have Calm, which is the meditation app, run by a bunch of Brits. Why Brits, having conquered the whole world and could advance everywhere they go and now doing meditation, I don't know. But anyway, but you have, Calm and Headspace, these guys growing as well. But that to me is stuff that is, as Stephen would have said, that's an add-on. I mean, these people weren't getting treated before. Maybe they should have got treated. Maybe you should all have been doing meditation. Maybe you should have been doing cognitive behavioral therapy, but you weren't having, that wasn't something that a lot of people had before. Now, many more people are getting access to that. The question that Ian raised, and I love your point of view on this, Maggie, is telehealth, whether it's behavioral health for clinicians or for patients, whether it's, the sort of standard acute care replacement with, maybe I can look in your ear with a machine as well. Is that really going to replace stuff? Or is it just, as Stephen says, an addition? If it's an addition, we're already spending 19% of the GDP on healthcare. Where do you think it's going to come out?
So I'm just going to say, so Dick Lamb, who was the governor of Colorado for 12 years, and a friend used to talk about the arms race in medicine, so that every technology is additive. There are no substitutable ones. And so the other thing is, I go back to the cartel of the providers, the payers, and pharma. Are they going to reimburse this? When I wrote the book, I thought telemedicine and the electronic health record would be fabulous. And all I found is, and I've had to eat my words because the electronic health record has really made it difficult for docs. It's focused more on capturing revenue than care of patients. And Ian, you said, will it transform the health process? That depends on the cartel. Depends on the cartel. I think patients have a certain amount of power, but I think they're sort of like doctors. Try to get them to all work together, and it's very hard.
Maggie, do you see? I'm sure that some of the more progressive folks come and talk to you. Do you see any really transformational uses of the technology that are making you optimistic that the cartel, at least in some places, and I'd agree with you, it's there, can be sidestepped, or it's still being used mostly to add revenue, not to transform care?
So I think, that's a really good question. And I think one of the things is, so I'm a Kaiser patient, which means they get the same amount of money no matter whether I use it or not. So they have embraced, mail order pharmacy, and now telemedicine. Zoom, they don't quite have the Zoom thing worked out yet, but they have phone calls worked out. it depends. If we think about healthcare, it's really misaligned incentives. And until we start paying for the results we want, it's why all this quality stuff is just crap. We don't pay for it. It's slowly getting done. But as long as we're paying more, if you do more, take more out, longer stitches, I mean, longer incision, go deeper, you're going to get paid more. And so we don't really pay for cognition. A doc or nurse practitioner can stay up all night with a sick patient and get paid less than somebody who does LASIK surgery.
All right, so but that gets us to, you know, a couple of points that we've scratched out around on the gang before, but I think worth digging into a bit more here, which is, yes, so there's the cartel, and we've had some people on from organizations that are in the cartel, others who are on organizations who are trying to break up the cartel. But the underlying, you know, question is as Ian raised, is if you're an NPAT, an employer, or Medicare Advantage, are you going to start thinking about this as an opportunity to pay differently? And are you going to, and is there going to be potentially, I don't know, a Rebel Physician Alliance led way of doing this differently? So if you look at what Farzad Mostashari is doing with ALDAID, which is the sort of the ACO attempt to round up the independent physicians and teach them how to do it differently and teach them how to go at risk, and, you know, to basically get the primary care people to take back over the system. That is sort of counter interest to the big the big providers who were all written up in the New York Times this week by Sarah Cliff and others as, you know, dipping into the CARES Act for their funding while they're all sitting on their 6 billion, 10 billion or whatever, right?
Right.
Mayo was in there, and they didn't mention Sutter, but, you know, but what was it? There was a quote from Niall Brennan who said that if they've got a venture capital fund, they may not be needing that CARES Act. And there are about 60 or 70 providers with venture capital funds, right? So it does come back to that. Is anybody seeing that conversation happen? I know I've been pushing this, and I don't know if I'm alone in pushing this.
Well,
Let me ask a question. Sorry,
Yeah.
let me just ask a quick question. So one of the things we're seeing is that many conferences that we've gone to in the past are now online, right? Trainings online. If they're charging, and universities are having this challenge, if they're charging us the same for an online conference as they're doing like when we were there, I don't know about you, but it doesn't seem quite fair, even though to them it's taking the same time. So I think for payers, I think that as they, and patients too, as they realize, you know, it's easier to do it, I think that will drive it. It'll be the paying part of it. Go ahead, sorry.
No.
I've been on a number of online conferences. Their prices were lower than real life conferences for me. And they did invite me to go into networking rooms between sessions. And I didn't do it. I'm the kind of person who would do that, but it just felt so odd. You know, one of the session, one of them was if you like a certain topic, go into this room and chat with other people who like that topic. Another one was if you're from the Asian subcontinent, and then go there to meet other people who are from the Asian subcontinent. I just drank a coffee and you know, read Twitter instead of going into the chat rooms. But that's supposedly something that a conference can offer you, and I think that there's some, you know, we haven't figured quite out that quite out yet. So, but on the payment question, so let me answer that in two parts. Two of the biggest budgets is the employer budget and also the provider budget. And so in the employer budget, really interesting things are afoot there, which is that forever employers have wanted to buy these health benefits on a success basis, and vendors have wanted to sell them on a member basis. And so employers are going to have the clout to do this, and benefits companies, there's so many of them, they're so competitive with each other, they're going to have to step up and offer some kind of success basis. Right now, things are kind of frozen, but when employers start making decisions again, they're going to be asking for this. And so I've heard benefit leaders say things like, companies are literally coming to them, young, small, innovative companies coming to them and saying, can we just give our product to you? Because they're so, you know, their normal sales channel has been blocked, and they have to show some kind of success, some kind of lighthouse customer. And so I think giving you the product is the ultimate kind of success-based pricing. But employers are finally going to have that leverage to be able to go from utilization pricing to risk-based pricing. And that means that these young innovative companies backed by venture capital, they're going to be financing the balance sheet of these large enterprises they sell to. It's kind of not, it's not the way that it usually works, but it's because it's so competitive. There's so many companies, so they're all funded. So that's the first. Then when you deal with providers, this is the biggest question of all, which is the shift to fee for value, which has been going on for a while, and which, you know, what's going to happen now. And my own thesis, which may be controversial, it may be contrarian, is that providers are not going to want to shift anymore to fee for value. They're going to want to stick with fee for service because they know that, and they just need the revenue, and they need the comfort of knowing that if they get people in the door or in the online waiting room, that they're going to get paid for that. And when it comes to the population, you've got issues of deferred care and also sickness that they don't understand. So they don't know, for a population they were going to bid for before. They had a pretty good idea for the year 2019 when they bid for that, what that population was going to cost them to serve. But now that population, you know, could have sequelae from COVID. It could have deferred care issues. Who knows what it's going to cost to provide care for in the year 2021? They want to stick with fee for service. So I think, and that's sad because I represent not healthcare, but digital health. And digital health, a lot of these companies geared up for the great shift over to fee for value. Buying their software made more sense in fee for value. And so to see that shift be slowed by this emergency is a concern.
I would agree with that, and I think you have to throw in something else, is that I think the country appreciates the demoralization and the stress that doctors and others are undergoing more after COVID than they ever did, right? I mean, we've seen it on our TVs every night. And fee for value is this sort of amorphous kind of thing that the wonks get. And yes, in the long run, fee for value is going to come. Medicare is going to give up all the rest of that. But in the short run, when I take a look at my local provider, and if I didn't happen to know that my local provider happened to have $1 billion in the bank and the doctors call it the mutual fund that owns a hospital. But if I didn't know that, and I was just your average citizen, I would say, my God, these people have suffered. They gave up business to be prepared for an emergency. They've been heroes. Why are we kind of screwing around with this weird payment? And I think when you add what Steve said, which is you can't tell about the population and what's there, it turns out the virus didn't go away by summertime. I mean, when you put in all those kinds of things, I think that we're going to pause, unfortunately, in some ways justifiably, fee for value, because psychologically and in all the objective ways, we really need to take stock. And, you know, we've seen this is not a time for those kind of paradigm shifts. Now, they still may go to digital for some things. Matthew, when you talked about the Medicare Advantage companies be a force for change, I don't know, they're earning money hand over fist. Does that tell you that they want to have extra change where they're disruptive, or just continue to earn money hand over fist? So I think
that's an interesting point, Michael, right? Because in most other markets, eventually you'll see people who put together what, you know, I've been imagining and talking about for the last few weeks, the different parts of what you would do to manage a population acutely, chronically, and all this stuff. And you do it with the telehealth, and you do it with remote monitoring, you do it with a sort of engine, AI engine underneath, which would figure out who's going to be sick and who's going to get sick. And then you would basically say, go to the cartel and say, don't go to the cartel, say, screw you to the cartel, go to the end payer, you know, instead of Medicare Advantage plan, the Medicare system itself, Medicaid, maybe, if we didn't get on, we need to get on to Ian's point about Medicaid in the last few minutes we have, and say, we're going to take over, we're going to do it better, faster, cheaper, and goodbye. That's never happened in healthcare, as we know. Kaiser's never grown that fast, even though it's had the potential to do that. But, you know, there is an option, the possibility to do that. Now, politically, of course, everyone can go back to fee-for-service and be quite happy. And that's not what you're actually hearing out of CMS. Not that I'm the world's biggest Seema Verma fan, but she has been saying that the genie's out of the bottle. They're going to go to more for fee value. And who knows about the politics of this when you get into the Biden administration, which may or may not be coming. However, there is the possibility of doing that, so using this technological shift, and eventually, and I've been looking bizarrely because I'm trying to figure out whether I should do it for my house. I've been looking at the price of solar power and the technology shift there, and you know, you do the charts out, and it's just so much cheaper and easier and better 5 years out to do solar power and solar electricity than it is now, and eventually you see the cost of electric cars coming down. That sector is going to completely change because of the technology. And I'm wondering if the stuff that Maggie's been writing about for 20 years is finally going to, and Steve and me have been looking at for 10, is finally going to start, being so cheap, so much better, so much cheaper, and have so much better outcomes that you won't be able to keep the cartels together. That may not be a 1-year thing, but maybe it's a 5 to 10 year thing, or maybe it's never. I know we could go through it. I do want to change the topic because Ian raised something which is really important about state budgets and about Medicaid expansion, and we've only got a few minutes left to talk about that. Ian, what's your, and I'll get perhaps Kim to weigh in on this as well. Ian, what's your guess as to where we are? I talked about earlier about people who are sitting there with signs saying I've got no unemployment benefit in Florida. I couldn't even sign on to the system. We talk about expanding Medicaid. We haven't got it in Florida, Texas, some of the other big red states. What's your sense about where that is politically?
Well, I mean, I've been trying to track, the various models, the Urban Institute, the Kaiser Family Foundation, some of the others, Health Management Associates, and it seems to me they're all in the right ballpark. It's something like a 20 to 40 million effect on the downside to employer-sponsored coverage, right? And it connects to the previous conversation. I wrote a thing for the blog, what was it, last week, Matthew, about are we going to restart the game, which the game being paying 300% of Medicare for elective surgery. That's how the game works. Is the game going to be like that going forward, and our employer is going to be complicit in that? And I'm talking to them and they're saying, we might seize this moment to finally get our act together and develop a spine. That's another topic. But I think the challenge for the states is this trickle down of problems where you've got the state unemployment burdens that fall on states that are not going to be picked up by the Congress or in this COVID related stuff. You've got increased Medicaid rolls, albeit they're expansion populations, but the states have still got to come up with the 10%. Plus you've got the devastation in the long-term care industry, which needs reinvestment. And that is a disaster. And that, if you look at where Medicaid money goes, it goes to old people and disabled people. It doesn't go to newly covered folks. So there is a cascade of problems at the state level, which is forcing even a democratic and liberal state like California. I mean, if you looked at Newsom's budget, he's cutting $54 billion in lost revenue because most states don't have state income tax. They're dependent on sort of sales tax of various forms. And you look at what's happened to the restaurant business in every state. By the way, I just discovered this amazing data set, which is Open Table's daily booking level, which actually is really, really interesting. If you look at the bounce back, in the opening, even states like Texas are still down 61% from where they were before. That's Florida's down 62, Alabama's down 58. The big surprise is Rhode Island in 2 days went down to 33. It's all those bloody New Yorkers coming up for the Memorial Day weekend, and they went from like 60 or 70% down to 30% down. So I think Rhode Island is going to be the hot
one place in America it's hard to get a restaurant.
Right, exactly. But anyway, you just put that all together, and it's a cascade of problems that puts pressure on pricing because you've got more Medicaid. You're probably going to see proposals in states like California to cut Medicaid reimbursement rates, which does further exacerbates the teeter-totter, as you Americans call it, of the hydraulics of having, because when I'm talking to the big employers, they're terrified that they're going to have to pay much, much, much higher prices in 2021 to make up for the lost revenue on the one hand and the impairment of public payment on the other.
Yeah, I was thinking about this in the piece I tweeted out about, I think it was Saturday, but it ended up being they had 3.5 years to spend down their reserves, the amount of money, the rate they were losing money in April. But at some point, they've got to figure it out, right? And one is to go back and ask the employers for much more. It was 300% of Medicare, now it can have 400%. And the other way is to figure out if there's a deal to be cut with either the states or more likely, I think, with the feds and CMS over what George Halverson wrote about, which can we get Medicare Advantage for all support or some kind of
Right.
guaranteed payment. So we are, Kim, can I quickly drag, we've got like a couple of minutes, can I drag you in on this? Because I've been looking at the sort of the future of the health system for a while.
I mean, the two troubles that have always been true about value-based purchasing of any sort are we don't really know how to measure value, and nobody really has a long-term incentive. You know, employers, their employees turn over, they change their carriers, even if they're self-insured. So even Medicare Advantage plans, they can't count those people are going to be there next year. So who wants to make investments in improving people's health for, 5, 10 years down the road when they're going to be someplace else? So when we talk about value-based purchasing or whatever, I'm not sure we have a mechanism on how to do that correctly. To what Ian was talking about, if there was ever an argument not to have either an employment-based system or state-funded Medicaid systems, an economic collapse like this is it. But does that mean we're going to have Medicare for all? I don't think we're over that teeter-totter yet.
Yeah, I mean, I've heard very little about that from anybody, apart from the people who are already pushing Medicare for all, saying it's terrible. But there's no big scale. You haven't had Biden come out and say, well, all that stuff I was saying about how expensive it is, that's kind of ridiculous because we just spent $3 trillion propping up the system,
Right.
Well, I have heard AOC say that.
Right. Yeah.
She's not the mainstream Democrat yet.
Yeah, we spent $3 trillion. All we need is another $3 trillion to pull a Bernie. I mean, it's like I think the numbers get just out of order. But I mean, one signal event was that Polis, the governor of Colorado, pulled his public option proposal because it was basically paid for off the back of price cuts on hospitals, and a lot of this stuff ties together. Whether you can go after hospitals in an environment when they've been the heroes, as we've all pointed out.
Yeah,
I wrote a piece about this a couple of years ago that instead of doing Medicare for all, what we should do is give virtual care to everybody right away. So that would immediately legitimize, telehealth for everybody, and start us down the road towards a more universal care.
I agree with that. I mean, I think a universal primary care system enabled by technology is actually a very good platform politically. Not, I didn't mean technologically, but that ubiquitous right. It's a bit like the way the Australian system works, where that everybody's in the same primary care system, but you can have private hospital insurance if you want a fancy room and your own a choice of specialist.
Ian, when you talked about nobody wants to pick on hospitals with this, I realized that in the current economy, poor underprivileged companies like United Healthcare and Humana and the others are actually serving the same function as the Civilian Conservation Corps in the Depression. They're supplying jobs because they're making so much money. So we wouldn't want to go to Medicare for all because then we'd eliminate all those clerks working for United Healthcare and everything. So if we're not going to have the Civilian Conservation Corps, if we're not going to rebuild our infrastructure, at least we can keep our bureaucracy going strong so that we provide jobs for bureaucratic Americans. It's really our patriotic duty, don't you think?
Absolutely.
That's it. So
I remember doing a retreat for Pennsylvania Blue Shield in 1989 or whatever, and I'd come from Canada and it had exactly the same population as British Columbia. We had 100 people in BC who did the claims administration, who paid doctors on a fee-for-service basis. They had 2,000 people doing the same.
There you go.
All right, so we're investing in public service, public utility health plans. It's going to be fantastic. That's going to be the future. All right, real quick, we have a couple of minutes left to go around the horn. So give me 2 sentences on what you expect to see next week or next couple of weeks. What are we talking about? Kim, I'll start with you.
I'm still waiting for the tail of the resurgence coming to hit us in the face, and maybe it won't till the summer's over with, but gosh, things have opened up really fast and they're not controlling it. So it's gonna slap us at some point.
Michael, next couple of weeks.
It's the tug of war between the resurgence as it starts to go in the South and the other states trying to play the morning after and figure out what they're going to do now.
Stephen, next couple of weeks, what are you expecting?
So I think we'll see more deals in digital health getting done because this will be one of the bright spots of the economy, and some people have sort of broken the spell of deals not getting done, and we're starting to see examples made here. So that's a good thing. And then economy staying bad. The economy staying bad. Maybe we realize that it's bad. We start to realize that it's bad as well.
Maggie, next couple of weeks, what do you expect?
I'm expecting the spike to hit. I'm expecting those of us who are over 60 to do our patriotic duty and die of COVID.
Wasn't that Richard Lamb's idea?
No, he actually never said that way, duty to die, but we can talk about that offline. The other thing is I suspect that docs will prefer to continue to do more telehealth than seeing people in person. And patients will too, because they're afraid to go to the hospital. One of the things that's interesting, there was a strike, a bunch of docs had a strike in a hospital decades ago. Fewer patients died.
Yeah, I remember, was that in Los Angeles? I brought that up somewhere and I can't remember exactly where it was years back. That was something Vic Fuchs taught me in like 1989 when I was there. Ian, the next couple of weeks.
Oh, I think Rhode Island is going to develop a test for a New York accent and prohibit anyone ever coming from New York again, because if the open table data is right, they're going to have the mother of all breakouts.
I can't follow that. So we're going to wrap up. It's an hour in. It's a real fun episode of the THCB Gang. I want to thank regulars Kim Ballard, Michael Millinson, and Ian Morrison. I want to thank our guests, Maggie Carey, Steve Waddell. I hope you guys will come back and join us again soon on the Gang. This has been the May the 28th episode of THCB Gang. It's Matthew Holt signing off.